Good morning and welcome to the quarterly meeting for Healthcare for All Minnesota. My name is Dana Coulthard and I'm the host of the webinar today. We have a full agenda. If Ann Jones is able to advance the slide, please. So we have a number of people who'll be presenting today, including our board chair, Dr. Mark Brockie, Don Pilkinen, our secretary and treasurer, Joel Klemmer, who's going to be the moderator of our panel discussion. We have panel members, Senator John Marty, Representative Jennifer Schultz, and Senator-elect Ann Johnson-Stewart. We will also be having an update from Roach, the executive director of MNA, and a call to action from our vice chair, Ann Jones. Next slide, please. This gives you pretty much the same order of the agenda for today. Again, remarks from our chair, a financial report, our panel discussion, which will include a Q&A, and please put your questions in the Q&A box at the bottom of your screen. Rose is going to give an update on health system staffing and care delivery with COVID-19. And then we'll go back to Ann for the announcements and call to action and education and outreach updates, and then I'll do the wrap up. So if we could go to the next slide, please. I'd like to bring on our chair, Dr. Mark Brockie.
Good morning, all. Happy to see you all survived Friday the 13th. As you know, we have a treat today with a panel of 2 state senators and 1 state representative joining us. As you will see, they are a very talented group committed to bringing us good government. We're lucky to have people in Minnesota willing to serve the citizens as they are. The organizer of the Healthcare for All Minnesota letter writing group, Joel Klemmer, will be moderating their discussion on healthcare. I'm just going to address 2 items quickly this morning. The first one is to note that during the pandemic, Healthcare for All Minnesota and PNHP, that is Physicians for a National Health Plan Minnesota, have been working jointly to continue with educating the public in Minnesota regarding the state of our healthcare delivery system. We have produced 8 webinars, which have been distributed and then subsequently posted on our YouTube channel. Healthcare for All Minnesota continues to work hard in spite of the pandemic to educate and energize Minnesotans fighting for affordable healthcare for every Minnesota resident. The next item I want to address relates to 2021 and fundraising. Just this week, the board made a decision to hire staff in 2021 to allow us to be more effective in organizing and educating Minnesotans. This will require us to have a steady and adequate source of revenue. I want to thank those who are already supporting our work. We appreciate your commitment to achieving our goals. I need to be clear, however, that we need to get more of our moral supporters to also become financial supporters in order for us to succeed and make the greatest progress. To that end, this last week, we sent out our year-end fundraising appeal. As many of you know, Give to the Max Day is coming next week. As you make your decisions on what organizations to support this year, we hope that you will include Healthcare for All Minnesota. As this is a community effort, I ask you to consider mentioning Healthcare for All Minnesota to your friends and neighbors as an organization deserving of their support. Now, in an effort to keep us efficiently moving forward this AM, I'm going to turn the program back to our hostess, Dana.
Thank you, Mark. Could we have the next slide, please? So up next, we have our treasurer's report from Don Pilkinen. Don, if you could unmute and come on video.
Hello all, can you hear me?
Yes, we can hear you, Don, but you're not on video.
Okay, I clicked start video and nothing is happening. Oh, start my video. Okay.
There, now it's on.
All right, great. It's great seeing you all virtually out there. I was kind of late coming to the meeting, trying to find the link, but I'm here. So that makes me glad. From our all volunteer efforts, we now have $31,000 in our bank account. And so far this year, we've raised a total of $19,000 from 94 individual donations and 4 larger amounts from the Minnesota Nurses Association, the St. Joan of Arc Fund, the UCC, Anoka, and a Crooner's Supper Club event. Furthermore, we just came off of an October walk, run, and swim-a-thon in which 7 participants raised $3,600 from 35 donors, family, friends, and colleagues, which reached 72% of our $5,000 goal. This first-time success deserves a shout out to Carol Engelhardt for initiating and organizing this innovative fundraiser, and to Dana for helping to set it up. We will be doing this again next spring due to its donor appeal. This demonstration of volunteerism and public support for HCAM gives credibility to our recently incorporated HCAM Education Foundation to do research and education on our mission of healthcare finance reform, for which we've submitted a 501c3 application to the IRS. As previously reported, the foundation's 501c3 status will allow you to make tax-deductible donations directly to our website. And the credibility and necessity of its research and education project in grant applications will be well received by foundations. Foundation money will be needed to fund $154,000 of expenses that include staff for the first year of an expanded statewide campaign, which is beyond the $31,000 that we now have in the bank. Getting the 501c3 status and applying to the foundations may take up to half a year. So in the meantime, we'll be using the $31,000 and more that will be needed to hire part-time staff by the second quarter of 2021. Hired staff will be needed to coordinate and facilitate the ever-expanding activities of our all-volunteer education, base building, social media, development, and legislative committees and our chapters. So going into 2021, we will be needing you and other supporters to help supplement the $31,000. To donate online, go to Contribute, go to the Contribute button on the right side of HCAM's homepage, which brings up the donation page where you can quickly click on the contribution amount and fill in the contact and credit debit card information. As we're waiting for 501c3 status for the HCAM Education Foundation, you can still get a tax deduction by writing your check to the COACT Education Foundation and putting HCAM donation on the memo line. Our work for our mission speaks for itself, for you to consider contributing. So thank you for considering this.
Okay, thank you, Don. I will include the link to the donation page in the chat if you'd like to take a look at that. Then I want to go ahead and introduce our moderator for the panel, Joel Klemmer, and he will take it from here. So Joel, if you could come on.
Thank you very much. And I might, is it appropriate at this time to ask our panelists to unmute themselves and to start video?
Yes.
So that would be great. And while they're fiddling with those buttons, I'll say a few words about each of them. My name again is Joel Klemmer. I'm a longtime health reform activist and member of HCAM and predecessor organizations, and I'll be moderating. I am a retired college administrator, and we are really advantaged by having a very talented and powerful group of legislators on our panel today. I'll say a couple sentences about each one, and then we'll get into it. First is, in alphabetic order, is Senator John Marty, who probably needs the least introduction of all of them. Probably many people on the call know that John's been engaged in issues of ethics, campaign finance reform, childhood health and education in the and healthcare in the legislature since he was first elected in 1986 to the state Senate. And he is the chief author, of course, of the Minnesota Health Plan that probably will come up in our discussion. Representative Jennifer Schultz, who I believe is now visible in our directory there, has a really interesting biography on her website. It's also very candid, describing childhood in a home that was dealing with substance abuse, but led by a very strong mother who was expert in those issues and also very politically engaged. Ms. Schultz went on from there to earn a PhD in health economics from the University of Minnesota and was elected to the legislature in 2014, replacing our old friend, former Representative Tom Huntley. She continues to teach at U of M Duluth and has worked as a healthcare economist at quite a few places, including United Health Group and as a faculty member at Cornell University. And she's traveled to Europe, especially Netherlands and France, to learn about comparative healthcare systems. Senator-elect Ann Johnson Stewart describes herself on her website as a civil engineer and describes pulling together her own small business in her basement in California and Silicon Valley. It's always the garage. Here in Minnesota, it has to be the basement for that sort of thing. She grew that business to 31 employees pre-COVID. As there's a quote on the site, quote, "I know the importance of government-supported infrastructure funding," unquote. And she also describes the circumstances of her motivation for running for the Senate in her district, which was a combination of many issues, but she especially underlines meaningful gun violence prevention. So I especially welcome her on many levels. And I also want to offer congratulations to all of our panelists for their electoral victories. Both John and Representative Schultz were in the 70%, over 70% range, and Senator-elect Stewart actually flipped her district. It was an open seat So special congratulations there. So finally, let's get around to HCAM and to the panel discussion. Just to set the stage, we are sponsored by Healthcare for All Minnesota, which I would describe as a nonpartisan advocacy organization dedicated to enabling 100% of our population to access quality healthcare whenever they need it. Most of us within Healthcare for All Minnesota would understand that to be possible only through universal coverage with reasonable costs. And we can talk about what that may mean. Many of us would name public financing, administrative simplification, and correction of the extreme market consolidation we've been seeing as critical factors. As a matter of fact, there's a video on the Minnesota Department of Health webpage I've been urged to let you know about that spells that out in pretty frank detail. We've made progress in getting those arguments across, and I think that'll be in our follow-up information. So finally, let's get the discussion going, and let's start. Oh, by the way, a couple of preconditions for panelists to jump in this discussion. Just please do look for an opening in the discussion, or raise your hand, wave your hand, and I'll try to recognize you, whichever works. I'll try to watch the clock. If we wind up early, that's great, but I may have to cut things off a bit. And a reminder to our audience that the Q&A button is available on the bottom of the screen. Drop your questions in there. And after about 30 minutes of discussion, Dana Coulthard, who is the person, as you've noticed, to actually make things run around here, will take those questions and consolidate them, edit them, and I will cleverly read them and ask for responses from our panel. So let me start off by asking the broadest of questions of our panel, of all three of you, about what you see as the strengths and weaknesses of our current healthcare system, and particularly what issues would you zero in on for reform in order to take it where it needs to go. I've mentioned some issues in the describing what HCAM is about, and so feel free to respond to those. We might go in alphabetic order once again, which would start us with Senator Marty, if he's available.
Yes, I'll go quickly. I'd say the COVID crisis has very much illustrated the nature of the problems. It's not only, it didn't cause them, it made them worse, and it made them more visible to people. Obviously, lack of coverage for people. The fact that a lot of people don't have comprehensive coverage is very obvious, and it's gotten worse during the COVID crisis. But it's not just lack of coverage and lack of affordability of getting care, which it was nice to see Republicans at least briefly joining in with some Democrats and saying, well, basically they wanted universal free health care for everyone, but just for this one illness. And that would help in this illness. And of course, quickly, well, we'll cover the test, but we won't cover the visits to get the tests and other things like that. But one of them is the cost and availability of access to healthcare for people. Obviously, other ones have come through is the lack of planning, the lack of coordination, the lack of PPE, and other things like that have shown up in this crisis. And we have hospitals fighting against each other, a competitive marketplace. That's really great when everybody needs PPE. Every hospital needs it. It's not a thing we want to have people fighting on. I would say that the problems we knew existed have been made more obvious by COVID.
Thank you. So Representative Schultz, how would you answer that very broad brush question?
So we have a lot of issues to tackle. And I think one positive thing of our current healthcare environment, or quote system, is that, you know, we have extremely good healthcare for some people in this country. And Mayo Clinic is one really stellar provider. And we're doing incredible research. at our institutions of higher education in terms of medical technology and improving health outcomes. But not everyone has access to that healthcare. Not everyone can afford the best healthcare. And we have huge differences in our community. People of color do not have the same outcomes. And that's true in Minnesota. In fact, there's 10 years of difference in life expectancy just in the city of Duluth, and it's mostly by income. So the high income neighborhood has much better outcomes of care and life expectancy than our lower income neighborhoods. But I think the big problem that we have to tackle is checking our prices. And so the prices of healthcare are astronomically high in this country. And part of that is that providers historically could charge whatever they wanted to and get reimbursed. And we have to get a handle on the true costs of care and help people understand and educate them about the differences between cost, prices, and reimbursement. But I want to look at new models of innovation and how we pay providers to tackle those high prices of healthcare. So that's one big issue. But you know, Health and Human Services, it's all about tackling not just access to healthcare, but all the social determinants of health if our goal is to improve population health.
Those were a list of big issues, and a couple of them I'd like to turn around to later in the discussion, as with Senator Marty's issues as well. But let's move on to Senator-elect Stewart about the 30,000-foot level view of healthcare.
All right. Well, I have to apologize for laughing when you described me as a civil engineer, because it sounded
that was
some are
your
civil and
description.
some are not. So that was the cause for the outburst. That was pretty funny. Anyway, I am civil and I am a civil engineer, so thanks for including me. I was actually encouraged to participate in this, even if I lost the election, because as a small business owner, I am voluntarily responsible for the healthcare coverage of my employees. And as you said, actually, we were 15 employees pre-COVID, and because I work in the construction industry, we actually doubled our staff in the last year. I think what Representative Schultz and Senator Marty said was true, and from an employer's perspective, I will add a few things. Like my employees, over 1 million people in Minnesota are employed by small business. Now, I said I voluntarily provide healthcare for my employees. I don't have to do that. And so there's a lot of people who are, even if healthcare or insurance is covered by their employers, it's tenuous at most. If I decided I couldn't afford that anymore, I could choose to stop covering my employees. I'm a civil engineer, and I am the person that is choosing the healthcare coverage for my small business workers. I don't know anything. I mean, I know things, but that is a high responsibility to put on a business owner. And because I have so few employees, up until this year, we really did not have any choice. I was able to pick one plan. And so that was not very popular with my employees. Some wanted an HSA, some wanted high deductible, some wanted low deductible. And I have a diverse group of employees. So what I had to do was really try to make a decision of what was best for them. And I only had 15 employees as of last year. The cost kept going up, but the coverage kept going down. So every year we would switch healthcare providers. And it's not really healthcare providers, it's insurance providers. So every year we would go from Blue Cross Blue Shield, then the next year maybe Health Partners, then now we're with United Healthcare. So I think I wrote the word myth down. I think there is a myth that we have a good system. It is not a good system. My opponent in our race kept saying that 70% of the people who live in District 44 are covered by employee-provided healthcare options. And that sounds great, like, oh, fantastic. But in fact, if they're like my employees, they don't have much choice. They don't have much say in how that insurance is selected each year, the cost goes up. I only pay 80% of my employees' cost. So even 20% for an employee is quite a bit. And this year we ended up going to a third-party provider because with 30 employees now, I just cannot manage the healthcare decisions for my employees. So we're paying a company called Insperity $1,500 a year just to manage those benefits. Now, as a small business person, I would love to pay that to somebody else and let my employees have an infinite number of choices. So I think from my perspective, I am well placed to speak to the concerns of small business owners. There's a 500,000, I just can't believe there's 500,000 people who own or manage a small business in Minnesota. And granted, many of them are married and they get health insurance through their spouse, but there's many, specifically as Representative Schultz said, who are minorities, who don't have that access, who are single parents, a variety of issues that we need to address. So what I want to bring to the Senate is a perspective of small businesses. There's a long list of groups that cover those people and say, let's get together and move towards a more reasonable system of coverage for people that is outside of employment and off my list of things I have to do as a small business owner. So it's a different perspective from the previous two representatives, but I think it's an important one, and it's an area that we can really make some headway in terms of reaching an audience who needs this problem solved.
Well, thank you. And I think we'll probably find some commonalities between what you said and the others. As a matter of fact, I'm wondering if our panel members have thoughts or responses to what they've heard so far from the others. Any ideas? If not,
I think I'd like to jump in and just comment,
yes.
and I forgot to thank everyone for inviting me to this panel, and welcome Ann to the Senate. So
Thank you.
congratulations. We're looking forward to working with you. But our system is our quote unsystem is very fragmented, and that's a problem. It's so fragmented that we're not coordinating care, which we need to do. But also almost every economist would agree that we want to take insurance outside of employment, because then people will have more choices. And I think a lot of large employers don't want to have to spend resources on doing that open enrollment every year. It's a lot of administrative expense that is wasted, and we could have the problem is they get this huge tax benefit. They can use pre-tax dollars to buy their health insurance. And so we need to get that same benefit outside of the employment arrangement, so they can go on the free market and pick insurance or a public option or something, but they need that tax break. But if we could see some large employers move in that direction, I think they'll all come along.
Mm-hmm.
So that.
Yeah. Oh, go ahead, Don, or go ahead, Senator Marty.
Senator,
I would add to the thing. I mean, first of
Senator
all,
Marty.
I think we should immediately remove it from employers and so on. And I don't want people to be, I mean, I think what we have to remember is when several people who were arguing against Medicare for all were saying, well, we want people to have a choice. They want a choice of health plans. I keep thinking, nobody wants a choice of insurance companies. They want a choice of which doctors and clinics and hospitals they get to. And I think Wendell Potter, the former Cigna executive, who said he was in their PR field, and he was one of the guys who came up with that line to say that, oh, you're going to lose your choice of insurance. And I think that's what the whole thing is, because Ann said it very well. I mean, why should she be choosing the healthcare coverage her employees get? We had the same issue with Hobby Lobby, where they were saying women shouldn't get reproductive care. Just bizarre. Why should the employer tell you what kind of care you get? We even had that with the Minnesota nurses when they were fighting at Alina a few years ago. Alina was telling them which kind of care, which doctors, which everything else they go to. Keep thinking nurses and the hospital system ought to know better than anyone the importance of leaving the choice up to the individual. So I really do think that's one of the reasons I say not just take it from employers, take the choice of insurance and replace it with the choice of doctor, clinic, hospital.
Absolutely. I totally agree with you, John. And something else I wanted to mention in response to Jennifer is we have also got this myth that healthcare is affordable if your employer pays for it. My brother is married to a woman who works for Marshfield Clinic. So Marshfield Clinic, if you're from Wisconsin, you know that it's very highly esteemed, much not quite as highly as Mayo, but it is the healthcare system for northern Wisconsin. And he has prostate cancer. And I said to him the other day, when are you going to get screened again? And he said, oh, it is so expensive. It's $2,500. And I said, yeah, but you have insurance. And he goes, that's the copay for getting another CAT scan. So my brother has gone over a year without getting another CAT scan. He has prostate cancer and he doesn't want to pay the $2,500 copay. So there's also this myth that if you're covered, it's free. And many of us have been in healthcare plans, me personally, where I get these, you can log on to your claim and I'm shocked. Why am I still paying $580 for this benefit when in fact, I have insurance. There's a myth that you pay a $10 copay and you're off the hook. And that is absolutely 100% not true. So I think we have to approach this from a marketing standpoint as well and break the myth that employer provided healthcare is free, because it's not. And the employer passes it on. It's not free.
It is part of total compensation. And what we're seeing is that the health benefit cost is eroding any wage growth costs. Yep. So it is a definite huge problem. And, most people are what I call underinsured. They have really high deductible plans. Maybe it's through their employer, maybe they buy it on MNsure, but they can't afford to go to healthcare, even though they're quote covered, because of their high deductible. And like you said, cost sharing. I actually was born in Marshfield, so I'm really familiar with the Marshfield Clinic. And I have a lot of family members who work there are under that same health plan. And so it is a problem. And researchers are now really looking into depth about even if they have coverage, can they afford health care? And people are reporting that they cannot. So they delay care, they don't fill their prescriptions. And that cost is pushed on to all of us because when they do get care, they get expensive care. And then we all pay higher prices in premiums. And so we have to really let people understand that this is a problem for all of us. Even if you have the best health care, it's going to cost you more if everyone does not have that same access.
So much of the discussion seems already to revolve around costs, and underneath costs, Representative Schultz pointed us toward prices as a driver of the overall costs. So let me turn it back to Representative Schultz and take advantage of her academic background in the subject and ask about why it is that prices in the United States for healthcare are so high compared to our competitor nations. And broadly, maybe you could help us distinguish between two broad schools of thought, if I have it right. One of which is a presumption that our use of healthcare is unconstrained and needs to be constrained. And the way to do that is through consumer-driven policies, such as the high deductibles that have been mentioned by Senator-elect Stewart, and by ending fee-for-service medicine. I believe you briefly alluded to new ways of paying physicians. So there is a school of thought that going to ACOs, the Affordable Cost Organization, I forget what it stands for, and other forms of value-driven payment to doctors will constrain waste within the system. Another school of thought, pardon me for going on like this, but another school of thought, I believe, points the finger rather at unconstrained pricing growth, because the entities that pick the prices have nobody really controlling them. and get reimbursed no matter what they choose to charge. So there seems to be two ways of approaching that. And I believe you may have found in France and Netherlands that there are background mechanisms of negotiation on prices that head some of that off. So with that long-winded introduction, can you help us understand where we go with pricing?
Well, the first one is easy to answer. So we have higher prices than every other country because providers can charge those higher prices and they've been paid. And so there's really no constraint there on prices. Where we once had insurance companies helping us constrain those prices, now provider groups have consolidated. We have these huge systems. They have more bargaining power than the health insurance companies. And so they're able to charge more, and the health plans are not able to negotiate deep discounts as they once had some power to do. So that's why. There's a really good book by Uwe Reinhardt, who's he passed away recently, but he's a well-known health economist from Princeton. And I require my students to read it every semester. It's called Priced Out. I encourage you to read that if you're interested to get more data. It's a pretty quick read. But you know, your other questions, yeah, we have to pay providers to improve health outcomes, not just to provide services, because a lot of the services, especially when you look at research in the Medicare area, is not necessary. So we're doing a lot of unnecessary procedures that may not extend life or improve quality of life. So we want providers to spend more time with patients and care about outcomes and other social determinants of health. So really care for the whole patient and improve their environment that they live in. So that's a goal of changing how we pay them. But I went and got my degree in economics because I knew what economists were talking about in terms of healthcare was problematic. So a lot of economists have been very influential in convincing people we should fix the consumption side of healthcare. And that's why we saw this huge increase in out-of-pocket spending on healthcare. And there's a group of economists that don't believe what we call moral hazard is that big of an issue. And that we've been probably giving some wrong advice to policymakers, that we need to look at the supply side as well and not just rely on consumers. And how they can't really shop for healthcare. We don't have quality, we don't have price information, nothing's transparent. We can't rely on consumers to shop for healthcare with the limited knowledge they have. We have to look at that supply side. So there's a lot of reform, but frankly, in this country, we have to have a discussion at a more basic level about healthcare being a right. And we have to be able to accept the fact that not everyone is going to be able to work and pay for healthcare. And we have to get to a point where we're willing to subsidize care for people who are older or can't afford it, and pay less when we're in that position. So young people, if you look at actuarial tables, just for health insurance premiums, young people pay less, and older people, young people pay more for the health insurance and older people pay less. They're consuming more. And we've accepted that type of contract for a long time. We just have to make it much more transparent and subsidize healthcare for everyone, because ultimately it helps not just individuals, but it also helps businesses, right? They get more productive employees, healthier employees, and people who are healthier are going to be able to consume, which helps a lot of industries that are selling things. But I think we can figure out prices. And I would love if Minnesota was a leader in changing those incentives for providers.
So very briefly, before I turn it over to our other panelists, the advantage of being moderator here, do you know of examples of very, very large, such as national healthcare systems that have been built on the presumptions of paying for outcomes and value in medical outcomes?
So we do have examples. We have systems like Mayo and Kaiser Permanente who pay their providers a salary. And they don't say you only have 15 minutes to see every patient. they do measure outcomes, and they measure the performance of the physician, and they track it. And physicians, they share that information with physicians, and physicians tend to be pretty competitive with one another. And so they want to do better than their peers in terms of patient outcomes. So putting physicians on a salary is one solution to how they can get paid, and I think could be adopted. We also have Blue Cross and Blue Shield is working with Alina in our state in Minnesota to do different types of payments for paying them based on outcomes and performance. So they're pushing more of that risk onto providers, and now providers, I think, with the information that they're getting, are willing to accept more risk. And we need to see more of that. So I'm hoping health plans can all move in that direction and change the way they pay for providers.
Could I open it up to our other panelists here? This is a very meaty discussion.
I will push back some on the pay for quality and so on. I think we should recognize that 99+% of our economy outside of healthcare pays people on a fee for service or a price for product. And that's the way the economy works. It's not a perfect system and so on, but we set up all this huge bureaucracy. I think most of you have seen the chart that PNHP put out, that over the last 40 years, number of health administrators has gone up like a 45-degree curve on their thing, a 33-fold increase in the number of health administrators in the past 4 decades. Number of physicians is about doubled or tripled. So in other words, it's a very flat line across the bottom, very steep upward climb in the one. And I think we keep trying to provide people the incentives to do it. And I think I agree with Representative Schultz that doctors want to do the right thing. They would rather outperform, get better outcomes for their patients. And I think that the simplest thing we should do is try and have a healthcare system where people provide medicine to people. They provide medicine, not just drugs, but they provide care for people. And they do it in the simplest possible way. And to me, like the Blue Cross, Alina deals and so on, I just see that as more bureaucrats and more bureaucrats. And now they try and take over. Well, I've always not tended to use the word single payer for discussing the universal healthcare system because people don't understand what it means. Now it's caught on enough that people like it. And now some of Elliot Fisher, who I think was heavily involved in the Affordable Care Act reforms and so on, is now gotten to the point where he's saying, well, we've got a fruitless debate between single payer and multi-payer approaches to universal coverage. So they're now calling things single system and single everything else, which strikes me as trying to take a very convoluted idea and say, we want to do something simple. And we're saying that's what the whole healthcare system should be. I'd like it to be where we pay doctors and clinics and hospitals to go out, find the care people need, give them the care they need, and get them done with it. Because frankly, if you have a single system, a simple single payer type system, you can negotiate the costs. When Fairview system is shutting down right now, St. Joe's Hospital in St. Paul, one of the most important hospitals for mental illness and for chemical dependency treatment for the lowest income people in the East Metro area. When they're shutting that down, well, we can't make enough money we're losing money on mental health beds. Well, so the solution is shut down the hospital that's providing the care when we're short of those things. Why don't we change the way we pay? Pay hospitals less to do the profitable surgeries, pay them more to deal with the mental health that they're losing money on. It's not a hard thing to do if you have a single system. It is hard to do if you got Blue Cross and Health Partners and Medica and UCare and the state and everybody else doing it that way. You can't really change the prices, but the pricing thing, because I agree with Representative Schultz, Ann is saying the same thing. We got to deal with the pricing, and I think we can do that, but let's do it in a logical way, just paying for what we want and trying to encourage the right things by paying people to do it.
So I would love.
I would like to add a short feedback. I am not an expert in healthcare costs and coverage as much as my two colleagues here, but I do want to add something that, you know, I'm a teacher at the university, and when we look at performance measures, one of the things that we base them on is our core objective. All right, so objective first, then how are you going to measure if you meet that objective? And I think there is a relationship between your core objective and your performance measures. And I want to bring it back to what Jennifer said about Mayo. Both my parents died in the care of Mayo. That's not because they got poor care, it's because they had terrible cancer. And what I realized as a family member going through that system is that none of our concern was about the cost or the coverage or testing or anything like this. All of our concern was on my parents and their healthcare challenges. And we would have meetings. They would require my 4 siblings and I to be in meetings with a team of 15 healthcare providers. And we would sit there sometimes for an hour and talk about my mother's care. And for me, that's a perfect example of your objective is patient health and patient care and patient quality of life or death. And so then their performance measure is not how much money did we make, how many tests did we provide, how many blah, blah. The performance measure is satisfaction and quality. And those are things we can measure. I will speak to anybody I know about the experience of my family seeing through the death of my 2 parents, 2 years apart, but they both happened at Mayo. And the quality of care they received was phenomenal. And I hope you've seen the documentary on Mayo and how they have really been a pioneer in that way that we create salaries for doctors, et cetera. But I just want to emphasize, as a receiver of that care, it was absolutely a total of 100% different experience from what I've experienced with my own children, et cetera, going through a different system.
Senator-elect Stewart, let me change the subject a bit and get it back to an area where you indeed have expertise, and that is business and healthcare reform. HCAM is always reaching out to other organizations in an attempt to build coalition to get something done. And frankly, and I've seen this personally, one of our most frustrating stumbling blocks is the business community, which hears something like single payer. John was mentioning how that can be a scare word. And frankly, the blinders go down, and it's very difficult to even engage in discussion. It's been most frustrating. So I'm wondering if you have advice for HCAM on reaching out to the business community.
So in preparation for this, I printed out pages and pages and pages of professional organizations that help small businesses. I happen to be in construction, so we have a very heavy component of minority-owned small businesses that are struggling with these issues. And so my recommendation would be, and I don't want to be presumptuous, I'm sure that you've already done this, but expand the message and the outreach to small businesses, to entrepreneurs, to minority-owned businesses, to people who want to start a business. I think one thing COVID has shown us is if it was ever in doubt, people certainly can work from home. And now I know from myself that 25 years ago, I waited to start my own small business until after I got married, because I'm sure you'll guess why, I needed healthcare coverage. So I think there is a message there for small businesses and for people who want to work from home, but for their own self. The other thing I want to add is I think for businesses to realize that there's many employees who are staying employed by them only for the medical insurance. And I'm looking at John. I know we're in about the same age bracket, but I'm sure we both have friends, and Jennifer, you probably too, who are at that age where they'd love to retire, but they frankly can't, because there is that gap until they hit age 65. I bet if challenged, we could all write down 10 people who are staying at a job that they maybe don't enjoy or they're done with, but they can't afford to retire because of insurance. And as a message to business owners, we say, let these people move on with their life, and it allows you to bring in new blood, new people, whatever. I think it's a strong message that we're missing, is all the people who are literally trapped in jobs that they don't enjoy. And it's not necessarily people who are in their 50s and 60s. I have a family member, I don't want to out this person, who has worked at the University of Minnesota their whole career and doesn't want to be working there anymore, but they cannot afford to leave because of the healthcare coverage. So I think that's a strong business message.
Right, and we have noticed a difference between, say, the chambers versus the little guys out there in the business community. Big difference. So in our remaining minutes, I wanted to turn it back to Senator Marty and to ask the question, since you've been involved in this for so long, and the Minnesota Health Plan has been out there with some success, 2 positive committee votes, I believe, in previous years. Yet we haven't gotten over the goal line, and HCAM and others have continual discussion about measures that could be taken that are both useful to the movement and perhaps might be more achievable. And I'm wondering if you have advice for advocates on that score.
Sure. A couple of things. One, yes, I will say Minnesota Health Plan, and frankly, a lot of the other proposals I would have as smaller steps, have almost no chance this year with the Republican majority in the Senate, and is a very, very, very welcome addition, but we could have used a couple more ands, a couple more bodies, period.
Yeah.
But we don't have that, so it's not going to pass this year. But I also don't want us to push up. Well, you know, someday we can do this, because I saw a commentary a couple of years ago in a Catholic social justice journal saying, "Oh, Democrats should be careful how fast they push on single payer. They're rushing it too quickly." And I thought, I wrote a commentary in response saying, you know, we've been waiting for close to 100 years. Actually, Francis Perkins during the New Deal was pushing for it. And it's been at least 80 years of pushing for universal health care. And when are we going to get there? So I don't want to keep saying, oh, we can't get there now, so someday we will. I think we have to make it much more concrete than that. But it's true, we're not going there this year. What I was planning to push this year, because I was hoping we were going to be in the majority, we're not, was something I've been calling, because other states have something similar, primary care case management system, which would basically throw the health insurance plans out of our public programs. They're state programs. They should be run, paid for by the state, and run by physicians and clinics and doctors and the people who care for people, not by a middleman. And we would get rid of the middleman, and some of the savings from that, which there are savings, some of the savings from that we would use to pay for nurses and grants to low-income clinics, the federally qualified clinics, pay them to hire nurses and social workers to go out and deal with people on the streets, people who would be qualified, in many cases would be qualified for Medicaid if they were getting the care, but instead they're not getting care. They're using detox or using other services. They're being housed in our jails. Get them care out front. A primary care case management program, I think it would be a simple thing to administer. There are some difficulties in getting it started because of some of the budget gimmicks we've done in the past in the state. It's complicated to get into. But bottom line is, I think we've got to start breaking down this thing, the difference between people needing care and people needing insurance, because not everybody who needs care has insurance, and our whole goal should be to get care to people. I'd argue an ounce of prevention is worth a pound of cure. We get people taken care of up front. It's a lot smarter and cheaper.
Good. Senator Marty, in the past, in addition to PCCM, I've heard you advocate that the state have a look at costing out healthcare alternatives, inclusive of a universal plan at the state level. Is that still
I would
a
like
live
that
possibility, or?
With the Senate majority, I doubt it, but I don't know. And that is an economic analysis we've been trying for a number of years. Mark Dayton, actually 1 year he put it in his budget. We didn't get it through the legislature that year, but a budget to analyze the cost, not the cost to government, but the cost to our economy, cost to our businesses, the individuals, families, and government of a universal health care plan like the Minnesota Health Plan. Compare that to what we're doing now. We're spending $50, $60 billion a year on healthcare now. And would it be cheaper? Because I would argue it definitely would be cheaper to cover everyone for all their medical needs with a universal logical system than what we're doing now. And so I'd love to have that analysis done. I don't know. I think it's very uphill battle with Republicans in the Senate being in charge.
Yeah, okay. We're starting to eat in a little bit on the Q&A time, but I wanted to ask the panel whether you have quick opinions on the notion of the voluntary buy-in to healthcare programs such as MaineCare. That's being discussed on the federal level as well, of course. Is that a solution or is that a sideways move?
I got my mic unmuted, so I'll just quickly say I think it's a step forward. I'd vote for it. I don't think I don't think it solves anything. It doesn't bring down any of the costs of the system. It's one more insurance provider in a sense for the people who are buying into it. And I mean, they're less than 3% of our population are buying through the exchange in the first place. So it's not a huge number there. You allow small businesses in, yes. But knowing how insurance companies are good at cherry picking, even when they're not supposed to under the Affordable Care Act, they're going to find a good way to push people with diabetes, people with cancer out of their thing and into the public system, which may mean it's not sustainable in the long term. But yeah, I think it's a good thing in the short term, but I wouldn't spend years fighting for it.
How do the other panelists feel about that answer, very briefly?
Well, it's all about incrementalism. And based on my 20 plus years of experience on health policy, it's the way to go forward, especially in a divided legislature in Minnesota and in light of our budget situation, which we're facing a $4 to $5 billion deficit. So it is a small step. And if we can show that it's successful in terms of affordable premiums and good coverage and enrolling a select group of people in, and we can do it well, the government doesn't have to make a profit. We just have to break even, and not even that. But, when we have private companies come in, they are looking for profit or excess revenue if they're a nonprofit. So I think we should try it. I think we should have a discussion in the state about it and look to see what Biden administration, what they'll do, and if they'll help us with some federal funding to do a pilot of a public option. So I'm optimistic that it could go forward. I'm also optimistic about the Supreme Court hearing on the ACA right now, that the justices, a few, are signaling that they may, keep the ACA, which will help in developing a public option using that infrastructure.
Right. Thank you.
And I would agree.
Last word.
Yeah, I just would agree and say, I think a lot of this is language. A lot of people have said to me, oh, you support universal health care. What about a private payer option? Or what about, people get very nervous. And so I think this would be a good way to demonstrate that it can be done, even if we help a very small portion of people to obtain care when they otherwise couldn't do it, or to obtain health insurance if they couldn't already do it. I think it's a good thing, and I think we could leverage it as a demonstration of how we can do it effectively and improve options for people, even at a very small scale.
Great. So I'm going to have a public word with Dana right now, if you don't mind hearing that, and that is that should I be looking somewhere for a consolidated list of questions? Or
Hey, Joel. Yes. So there's a chat box at the bottom. There's been a lot of chatting going on, but I tried to give you privately some of the questions that I kind of culled from the Q&A. So let me know if you can see those.
So I'm scrolling through the chat box and I am seeing a couple of them are marked private. And oh yes, they're from Healthcare for All Minnesota. So those are from you, and there's quite a few others. So
so you want to look at the ones from me.
Be disappointed.
Yeah, just look at the ones from me. And if you can't find them, I can also pose the questions.
Right. Okay.
Can I answer one of the questions in the chat from Susanna Patterson?
Yes, please go for it.
So she's asking about if you pay providers based on outcomes, providers are going to only select healthy patients and not, and physicians
Wow.
will get dinged if they only treat sick. So,
The
you know, we
gaming
can,
the system.
yeah, we can get pretty sophisticated with our incentives and look at the change in outcomes. And so you will get more rewarded if there's a big, large improvement in someone's health. And of course, physicians can't control all patient behavior. They can't force people to stop smoking or lose weight. So really putting them on salary and then just bonus structures for the improvement where they can make a difference, like, you know, get the screenings done, et cetera. But yeah, we would make sure the system, the payment system, doesn't penalize and controls for selection.
Good, thank you. There are a couple questions about outreach. What are the best ways to influence legislators? We're dealing with a topic here which we've already proven today can get into the weeds pretty fast, requires a bit of background to feel confident in navigating through it. Legislators are supposed to be experts about everything all at once. So there's a contradiction there. How can we be helpful to help legislators get to a level of understanding of this complicated issue?
I'll give a quick thing. One is contacting people frequently. The more people who contact the legislators, the more attention it gets. Oh, this is a big issue in my community. Of course, everybody's saying vote for this or vote against this. Doesn't educate anybody very much. And obviously, so some contacts are trying to educate somebody with a specific concern, a specific direction you hope they'll go. Others are just to let them know you're concerned about the issue, but more contact tends to be better. But it's a hard process to educate people. HCAM as a group and others can do some educating, but individuals, they can build a relationship with a couple of legislators perhaps and have a chance that way.
So find some champions, perhaps. I think
And I would just add that,
I'm looking at a few right here.
I would add to that find the Republicans and people in their districts to form, develop those relationships. And I think stories really help influence legislators. So bringing those stories to committee or to our Republican colleagues, because we're going to really need some of them to support these initiatives.
That's great.
Yeah, just piggybacking on that, I spoke to a group of transportation professionals on Thursday, and I know half the room is Republicans. And I said, if you really want to see more work in this area, please help me and talk to your Republican colleagues and your Republican representatives. And I think that's a way that we have to get the kind of through the back door behind the bunker, right? Because we can only do so much.
So there's been, I'm going to give another long-winded introduction to the question. In discussion of the recently completed election, progressive Democrats were accused of sort of spoiling the soup by advocating for Medicare for all and other reforms, and then being embarrassing moderate Democrats who then had to deal with the labeling. So there's a very relevant question that's popped up. How do we combat the socialism label?
I'll comment on that one because I will guarantee you that whether you support the Affordable Care Act or Medicare for all, it doesn't matter. If you're a Democrat, you're going to be attacked as being a socialist. That's the answer they're going to give you. We can talk about the fine differences because Medicare for all is not socialism. The VA is socialism. I mean, VA is all public employees of public hospitals, public everything else. Medicare for all is like Medicare. It's not a private, it's a public-private mix, a publicly paid for thing. It's like the Canadian system is not socialist. The British system is socialist. We're looking at one that would be more roughly akin to the Canadian system. It's not socialist. But again, I think the Biden made it a lot worse for himself when he said, oh, I'm not socialist, I'm not socialist. He's giving them strength to these attack words. He could say, I'm not in favor of what you would call, what people would say is socialism, but what you're talking about, what are you trying to scare people of? What are you trying to say? In other words, when you're on the run, as he's on the run from the term socialism, you make it much worse. When you're on the defensive, you're always going to be losing. When you're on the offensive and saying, here's what we want. We want something like this. So my response is, hey, look, if you're a Democrat, you're going to be attacked of favoring socialized medicine. You're going to be a socialist, whether you call yourself one or not, whether you are one or not. And so my best response is stand up for what you believe, speak out for what you believe, and ask people, call them out. Why are you afraid of these immigrants? Why are you afraid of this term socialism? What is it you're after? And then you respond. But when you're just running, you're just throwing everything out. Oh, I'm not that, I'm not that. You make it much easier for the other side to pounce. They know they've gotten a bite into you, and they're going to keep biting at you.
Sometimes
Thank
you just
you.
ignore what they say and you just talk about what do you value and how are you going to get that done. And so, we value that everyone has access to good health care, and that's what we want to do. And we just talk about how we're going to get there, and we can ignore that other stuff going on. But these message boxes about us versus them, our message versus their message, and we have people in messaging and PR and strategy that helps us as legislators work through that, and what words work and what words do not, are effective and not effective. So yeah, words do matter, but we want to focus on our message and not, like Senator Marty said, be on the defense. We always want to be on the offense.
Senator-elect Stewart, would you like to have the last word?
Oh, that's a high challenge. I would
pressure's
just
on.
agree. I think as a business owner, I have often wondered why does any business want to provide health insurance? What a pain in the butt. Like, I think we need to change the message, and we need to be out loud about it. I was called a socialist. I was accused of burning down Minneapolis. Of course, I had nothing to do with that. So we're going to get attacked whether it's true or not. And I agree. We need to be a positive, proactive, on the offensive, loud and proud messenger about what we all value. And I appreciate the work that's happening in the Democratic Party around this with the Minnesota Values Project and others. And I think it's true that we need to reach those businesses and say, this is not in your best interest. People already know it's not in their best interest. If they really think about it, having me or their employer, what if I was anti-birth control? I mean, when John said that, it occurred to me, if I was some very vehement opposer to birth control, I could take that away from my employees. It might save me $300 a year or something like that. But if I was a vigilant anti-birth control person, I certainly could do that. So we need to message this about common sense and moving forward what is really best for everybody.
So I'm going to call that the capstone comment. And which works very well that way. And thank you all very much for participating. Senator Marty, Representative Schultz, Senator-elect Stewart, thank you very much for your time. This was a great discussion, and I will turn it back over to either Dana or Mark, or I'm not sure whom.
Can I offer one more thing? I know how to save a chat, but I don't know how to save Q&A. Can someone please save those? Because I think they're really good for me in prepping up to get really well-versed on this subject. So can I just ask that before I go off?
Yes, we typically do copy and paste all of the chat and Q&A into a Word document. So, but I would just add too that if any of the panelists feel so inclined, they may go ahead and continue to answer people in the chat and Q&A as we move forward in the agenda. So we have up next Rose Roach, the Executive Director of Minnesota Nurses Association. Hi, Rose.
Hi, good morning, everyone. So I'm going to center my remarks this morning based off of what we talked about actually last June at the quarterly meeting. Some of you may have been there, and I'll highlight a little bit of what I'm talking about to help ground us in this conversation. You may recall that I did a presentation that was focused on why the healthcare system wasn't and still isn't prepared to deal with a global pandemic. And that's due in large part to the fact that corporations are running our healthcare systems like a business, implementing business models that may work in perhaps the auto industry, but they don't work in healthcare. Models such as lean management, which is a way to do more and more with less and less. Less human effort, less equipment, less time, and less space. And it's really comes down to a theory about minimizing costs, to maximize profit. Operating under the lean management model has caused a lack of inventory of personal protective equipment, a drastic shortage of nurses and other frontline healthcare workers, and a literal de-skilling of healthcare professionals. So here we are now in Minnesota, deep in a severe surge of the virus, much, much more significant than anything we encountered in the spring. We are at New York level crisis. We're out of beds, maybe not physical beds, but it's important to remember that an open bed isn't an open bed if it doesn't have a nurse to staff it. PPE is still in short supply, with some nurses reporting being told to use their masks up to 10 shifts, and PPE inventory in some hospitals are placed under lock and key because, to quote a hospital manager, if we don't lock it up, the nurses will steal it. Doctors and nurses are getting sick with this virus at record levels. At the same time the virus is surging, the system is shutting down beds and clinics, thereby laying off critical healthcare staff. To give you a flavor of what we're hearing is actually going on inside the hospitals, contrary to what the hospitals are saying publicly with their narrative about "we got this," here's some stories from around the state. We recently did a meeting with our nurses and nurse leaders from across all of Minnesota and even from Wisconsin. And here's what we heard. In the northeast corner of the state, our ED is overwhelmed, closed to all ambulances, meaning heart attacks, strokes are transferred because they're unable to take any more patients due to staffing shortages. We can't find any open ICU beds, which is resulting in 10 to 18-hour waits in our emergency department. In the northwest area of the state, a small critical access hospital with 10 beds, 2 ED nurses on days, 1 ED nurse at night. Hospitals in the area are full, so no transfers are being allowed. No testing is available for the staff. If you are lucky enough to find a test and get tested, it can take 5 to 7 days for the test results to come back. And nurses are having to use their personal PTO or sick leave or vacation for these days to be held financially whole while they're waiting for test results. In St. Paul, the capital city that apparently has some sort of a healthcare target on its back, at St. Joe's, the ED is scheduled to close on December 31st. They are already beginning to send patients 2 hours away, which is putting a financial burden on patients who live in the St. Paul area. Bethesda is now officially closed. So St. Joe's is basically just a mental health beds and COVID hospital, but they're lacking in all the necessary equipment to care for such a high population of the COVID positive patients they are receiving. In Duluth, a system is telling nurses there's no need to quarantine after a known high-risk exposure. Quarantine only if you're symptomatic. And to follow the corporation's rules, not the state guidelines on what should be done with a high-risk exposure. In Wisconsin, right on the border between Minnesota and Wisconsin, 25-bed hospital. They have no ICU. The nurse said, we're having a hard time trying to place patients with so few beds available in the Twin Cities and Wisconsin, where the beds are all full. They can't take vented patients at this hospital. More staff are being infected, so their staffing ratios have increased. Management said they can work if a family member is positive, as long as they don't have any symptoms, which is a big change from when this pandemic first hit last spring. They only have 2 negative airflow rooms. Many staff are out with COVID, and they're talking about trying to get travel nurses, but the truth of the matter is there aren't any, because the pandemic is hitting this country as a whole. And last, in the far, far north, who said that they are not quite as overwhelmed per se with the number of cases yet, but they've set up a testing site with RNs that are doing the swabbing, so they're running short on nurses inside of the facility. Nurses are being deployed everywhere, radiology, admitting, IVs. They're told they can work with both positive and negative patients at the same time. That's called cohorting, due to short staffing. The fact of the matter is that the hospitals have a significant role to play in managing this surge, and they haven't stepped up. They keep increasing nurse to patient ratios, even in the ICUs, with no other plan in place to deal with this crisis. To quote from yesterday's article in The Atlantic entitled, "No One is Listening to Us," quote, "They've pleaded with family members to wear masks and physically distance, lest they end up competing for ICU beds that no longer exist. As an Iowa nurse who was quoted in the article said, nurses have been the most trusted profession for 18 years in a row, which is now bullshit because no one is listening to us. The entire system is failing us. There is no better time for us as activists to demonstrate there is a better way to ensure the public's health. We must up the ante and work harder than ever to take our healthcare out of the hands of corporate elites and put it back into the hands of those who compassionately provide the care. Listen to the most trusted profession. No more trying to make a market-based system work at the cost of patients' lives. Single payer, Medicare for all, Minnesota Health Plan now." Thank you.
Thank you very much, Rose. Next on our agenda, we have Ann Jones. Ann?
Dana, can you hear me?
We can hear you, Ann.
Thank you. All my pictures disappeared from my screen. Oh, dear. Thank you. Thank you, Rose, for that straight talk. Just to a minute of personal privilege, or 30 seconds. I worked through the during direct patient care, ICU, OR, during the HIV/AIDS epidemic. That was probably 15 years of those patients while we developed our procedures and good therapeutics came online. And there were a handful of deaths amongst healthcare workers during that entire time. And I felt that we could actually handle the work we were doing with the guidance we got from CDC, which has been hamstrung now by this current administration. Did a quick look up. Something like over 1,700 US healthcare workers have died due to probably work-related contact with patients with COVID-19. They are exhausted. They are paying with their lives. We have to fix this. And then if you care about police, fire, and first responders, they are also at great risk. Anyway, part of what we're doing as an organization is education and outreach. We need more numbers to make our case for reform because of the current public health crisis. Education and outreach is now all generally virtual, which actually gives us some options for reaching out to a broader audience if we can get in front of people. So education continues to be our primary strategy for outreach. Having a little trouble with my slides for some reason. I'm sorry. Okay. I apologize. Maybe I'll go out and come back in. Okay. So our education committee continues to work on programs. Healthcare for All Minnesota is the lead organization, but Physicians for a National Health Program Minnesota is also participating with us. We have a volunteer committee that meets about every 2 to 3 weeks to plan events. We are marketing to our email list and via social media, but when you get an invitation, please forward that information to your personal contact list. That's what organizing and base building is all about. This is our primary outreach strategy to build our numbers at this time. The content is a combination of speakers, panels, and videos. And we are open to ideas for content and speaker suggestions. You can just go to the Healthcare for All Minnesota website and send an email that way, and we'll get it. Please also view and share the events recorded on HCAM's YouTube channel. We've done a lot of programs over the spring, summer, and fall, and we have recorded them, and they are available for you to view if you missed it, and they're also easy to share that way. So also view and share those Fix-It videos, which are on the fixithealthcare.com website. If you haven't looked at them, they're excellent. And we did some programs highlighting that information and content. So that's an easy way. That's kind of part of organizing, since we can't do as much in person, but you can always use this with your own personal network. Also help us get in front of other audiences. It's actually pretty easy to do virtual events, which is an interesting kind of sideline of this current public health crisis that we're in. Upcoming events, we're working on an interview with a metro area leader in the immigrant community with stories on healthcare access issues. We've got, there's an event coming up on Tuesday, sponsored by the Roseville League of Women Voters and the Roseville Area Advocates for the Minnesota Health Plan. And you can access that by going to our calendar and using the link on our calendar to view that program. It's a really good panel with Dave Dvorak, a physician for a national health program, Stella Obadiah, RN, and Senator John Marty. Also, please continue to write, call, and respond to action alerts from Healthcare for All Minnesota and Physicians for National Health Program Minnesota. We may also ask you to support and respond to action alerts with some of our key partners, such as the Land Stewardship Project and the Main Street Alliance of Small Business Association. Please go to the calendar at our website for other meetings and events. And please send any events scheduled for your local groups or events of interest that you think we should publicize. Also, again, we can provide a speaker for local events. If you have groups in your own local area, churches, business groups, issues groups, political groups, we can easily provide speakers either for a presentation, for a question and answer. You know, we could possibly get a couple people on for panel discussions. All very feasible. And then I'll throw down a challenge. What will you do when you leave this meeting today to make progress on this issue? We want to put patients before profits, and we want a system that works for everybody. There is one advocacy action that you could take related to the current public health crisis and all the people who are without insurance. I will comment on this again. These are two federal bills that have been proposed. I haven't seen any hearings. Again, we need constituent action to bring things to the fore with our elected officials, but we'll put this in the post meeting email for you, or you can take just get out your camera or your phone and take a picture of the screen. One last thing I guess I'll say is please have a happy and safe Thanksgiving. And I'll turn this over to Dana for a wrap up.
Thank you, Anne. Thank you to everyone who participated today. We have recorded this meeting and do plan to publish it on our YouTube channel. So please look for that. I'll put our YouTube channel in the post-webinar email, so you have a link to that. And, you know, we've had a number of requests for Rose's comments, so I'll follow up with Rose and see what we can do there. And again, thank you for attending, and keep in touch with us for future events. Thank you.